أبناء الطلبة السلام عليكم ورحمة الله وبركاته. Our lecture today it is about inflammatory bowel disease. Now, what is inflammatory bowel disease? Inflammatory bowel disease is defined as a chronic inflammatory disease of gastrointestinal tract of unknown etiology. Commonly, two important type of inflammatory bowel disease is an ulcerative colitis and the Crohn's disease. The difference between them that ulcerative colitis most likely localized to the large intestine, while Crohn's disease it can be affect any part of gastrointestinal tract from the mouth to the anus, but most frequently attack the distal third of the small intestine and the colon. Now, is there another example of inflammatory bowel disease? Yes, there is a collagenous colitis, lymphocytic colitis, ischemic colitis. Behçet syndrome can be presented with a sign and symptom of an inflammatory bowel disease. Infective colitis, we mean that infectious process, and intermediate colitis. Now, we have two peaks of incidence of inflammatory bowel disease, one in the second and third and fourth decade of life, and the other peak in the seventh and eighth decade of life. There is no difference in the sex, that means the male and the female can affect it equally, but it's seen that it is very common in a Jewish person. There is an increased incidence in the first degree relative of affected patient. That means it seems to have an hereditary pathogenesis of inflammatory bowel disease. Now, what is the pathophysiology of inflammatory bowel disease? There are multi-theory about the pathophysiology. Some of them, they said it is a genetic, some said environmental, immune response, microbial. It can any one of them, or it can be multiple theory that share its effect to form an inflammatory bowel disease. Ulcerative colitis common in non-smoker and in ex-smoker, while Crohn's disease common in smoker. There is a theory said that appendectomy can protect patient from ulcerative colitis. Diet, there is some role of the diet in the pathophysiology of inflammatory bowel disease, like low residue and high refined sugar diet. Infectious process, while bacterial or a virus can take a part in the pathogenesis of an inflammatory bowel disease. Now, what are the macroscopic features of inflammatory bowel disease? Now we will talk about ulcerative colitis. Usually involve the rectum and extend proximally to involve all part of the colon. It is usually spread in the continuity, and it might be limited to the colitis. So it might be involve all the colon, or still involve only one part, that such as the rectum or the sigmoid. For example, we call it the proctosigmoiditis. In total colitis, there is a backwash ileitis. That means it can be involve the part of the ileum. We called it wash ileitis. And this slide show which part of the colon can be affected by ulcerative colitis. In A there is a proctitis, in B there is a proctosigmoiditis, and in C there is a distal colitis, or it can be involved, as we said, all the colon, we call pancolitis, or it can be involved the distal ileum, we call it backwash ileitis. What are the macroscopic features of Crohn's disease? As we said, it can affect any part of the gastrointestinal tract, from the mouth to the anus. It can be a transmural, which a segmental or skip lesion, so that when we see by microscopic appearance, for example, during colonoscopy, we found there is an affected area, healthy area, affected area. We call this an skip lesion, or it might be seen as a cobblestone appearance, that like the picture in the below, and also it can be an adhesion and a fistula. Both ulcerative colitis and Crohn's disease have what we call waxing and waning in intensity and severity, so that there is a flare up of the disease and a remission from time to time, dependent on a certain factors. What are the symptoms of ulcerative colitis? Usually there is altered bowel movement, that means diarrhea with might be constipation. There is an increased stool frequency, decreased stool consistency, abdominal pain, commonly in the left loin or quadrant, left lower quadrant, and usually with pain with defecation. Also, there might be an tenesmus or blood in the stool, so that one of the differential diagnosis of bloody diarrhea is inflammatory bowel disease. Symptom of the Crohn's disease, and as we said, the Crohn's disease, it can involve any part of the GIT. So it can involve the small intestine, the large intestine, or other part. So when it is involved the ileum, we call it ileal Crohn's disease. Usually the patient presents with abdominal pain, diarrhea, weight loss, and low-grade fever. When it is involved the duodenum and the ileum, we call duodenoileitis, and usually the patient presented with malabsorption, steatorrhea. So it can be presented with other type of the diarrhea, اللي هي small bowel diarrhea. Also, when it is involved the colitis and perianal disease, usually هنا we start to involve a bloody diarrhea, which is a type of large bowel diarrhea, passage of the mucus, lethargy, malaise, anorexia, and weight loss. These two diseases have an important feature. It is usually not localized only to the GIT, but can have an extra-intestinal manifestation of inflammatory bowel disease. It can involve the musculoskeletal, or it can be involve the skin, or it can be a nutritional deficiency, or a hepatobiliary system, for example, primary sclerosing cholangitis, bile duct carcinoma, or it can be associated with other autoimmune disease. It can affect the eye, like uveitis, iritis, episcleritis, scleromalacia, and so on. Or it can be presented with the growth retardation in children and adolescents and delayed sexually maturation, or it can involve the renal system and the calcium. And also we concentrate high most of those patients, the commonest presentation, it is an arthritis. Usually this is as ankylosing spondylitis, or it is presented as isolated joint involvement. Most commonly it can be involved the large joint more than the small joint, and there is an peripheral joint. Right now we have a central joint. Central joint, that's mean involving the spinal, the vertebra, and the peripheral, that's involved the other joint, big joint in the body. So any patient presented with these signs as symptoms have inflammatory bowel disease? No, there is a differential diagnosis before we start to say that this patient have an inflammatory bowel disease. It might be as a differential diagnosis as anorexia nervosa, appendicitis, celiac seborrheic, especially for those patients with Crohn's disease and the involvement the duodenum and ileum can present it with malabsorption syndrome, or it can be a Clostridium difficile colitis, giardiasis, lactose intolerance, chronic pelvic pain, diverticulitis, pseudomembranous colitis, salmonella infection, and also these are very common differential diagnosis, the irritable bowel syndrome. How we diagnose a patient with ulcerative colitis? There is an laboratory test, endoscopic and radiographic, and biopsy. Laboratory test, for example, there will be an increase with the ESR, increase in the C-reactive protein. The patient might be presented with anemia. Also, the patient might have platelet count increase, and as we said, a decrease in the hemoglobin. But there is a specific test for ulcerative colitis, we called it a fecal calprotectin level that's be measured in the stool, and from the measuring of this type of material in the stool correlated with the histological inflammation, we diagnosed that this patient have an ulcerative colitis patient. Barium enema, there is a specific sign in radiological finding. There is what we call a pipe steam appearance, and there will be loss of the haustration, and there will be an ulceration of the mucosa. And actually in this picture, we said that this patient have a pipe steam appearance. Sigmoidoscopy, also it is abnormal, loss of vascularity pattern, granularity, friability, and ulceration. With that mean this is sigmoidoscopy used for those patients that have the disease limited to the rectum and to the sigmoid. While if we suspect that this patient involving the whole colon, we use what we call a total colonoscopy. These are the picture. In the left side, that this is a healthy mucosa. We see the vascularity, the redness, the mild redness, while in the right there will be loss of the vascularity pattern, and there will be bleeding, easily bleed, and more red color. How we diagnose a patient with a Crohn's disease? There is a laboratory test, endoscopic radiology, biopsy, and CT enterography. In the laboratory test, there will be elevated C-reactive protein, increased ESR, there will be low hemoglobin, anemia, leukocytosis, and hypoalbuminemia, especially for those patients that are presented with sign and symptom of malabsorption. That's mean to involve the jejunum and the ileum. Barium enema, there is a special sign we called string sign, like in patient with barium enema. In patient with ulcerative colitis, we found that this patient we have pipe steam appearance. Here we have a string sign as seen here. What are the complications of inflammatory bowel disease? It might present with what we call toxic megacolon. The colon will be distended and usually easily to be a rupture, and it might be lead to the perforation, and it might lead to peritonitis, and the patient usually become high-grade fever with the acute abdomen, and it is usually one of the surgical emergency, and this patient need a total colectomy. Or the patient, they have an abdominal pain distension. Distended bowel allow bacteria to dig, as we said, to the bloodstream, increase risk of perforation and peritonitis, and if no improvement, usually treated with colectomy. Why we concentrated on inflammatory bowel disease? Because inflammatory bowel disease, if leave untreated, usually it is a pre-malignant condition, so that it can go after many years. For example, 7 to 10 years, the patient can transform from inflammatory bowel disease to CA colon. As we said, also the patient might have stricture and can lead to obstruction. It can be a fistula and abscess, which is usually these more common in Crohn's disease more than in ulcerative colitis. Usually the type of the fistula, it can be many types of the fistula according to the organ involved, and also there will be cause involvement of the renal system. As we said, it might be an obstructive or hydronephrosis because of the compressing right ureter, sepsis, malnutrition in Crohn's. How you treat a patient with inflammatory bowel disease? Usually a diet change, as we said, one of the type of the diet, one of the theory in the pathophysiology of inflammatory bowel disease, lifestyle changes, drugs, and surgery. Surgery, we leave it for those for the surgeon to say about the type of the surgery according to it. For example, if they have a fistula or it have a perforation, should be treated as a surgically, or the patient have a toxic megacolon, might treat patient by total colectomy. Lifestyle modification, we're taking a rest, no smoking, stress reduction, and doing an regular exercise. Drugs, the common treatment used for inflammatory bowel disease, ulcerative colitis, and Crohn's disease. We have a 5-amino salicylic acid agent. For example of this, or the common example, هو salazopyrin. It can be given orally, or it can be given as an enema. Other type of modality هو glucocorticoids. It can be usually given as an systematic, or it can be given orally, or by as an enema. Antibiotic, usually there is no rule of antibiotic except for those patients if they have a peritonitis or toxic megacolon, or those patients with fistula. Immunosuppressant agent, there are many types like methotrexate, azathioprine, and we have the biological therapy, infliximab, and it is serious. Thank you very much.